All right, Dr. Hester is beaming in. Show everyone proudly your shirt.
Oh yeah, UMS.
Woo!
I decided to dress up for all of you today. You're welcome.
So we're doing day 2 of the awesome Micah Hester, following an amazing session yesterday on trans children. I know we're all eagerly awaiting his remarks today on assisted suicide, his research specialty. And I don't know if you have time, Professor Hester, but maybe you'd like to say a few things about the humanistic side of study at UAMS that you're running.
Look at that. That was a beautiful opening. Thank you so much. So I told you all yesterday, I'm chair of the Department of Medical Humanities and Bioethics at UAMS. Something to recognize. Now I'm going to take a longer story than I should, but it's all right. It's good for you all. The area of bioethics, the discipline of bioethics is an academic discipline. It didn't arise until the late 1960s. There were writings of various sorts. Earlier than that, a well-known book in 1954 by a man named Joseph Fletcher called Medicine and Morals spoke to some of this. As a kind of focused academic set of pursuits, the idea of bioethics, and for that matter, this broader umbrella we call medical humanities, didn't really exist until the late 1960s when Penn State University at Hershey, which is where their medical school is located, hired a man named Dan Clauser to be a philosopher in residence at the medical school. He was the first one of the kind that we know of to have done that. And after that, slowly but surely, things started to grow. So the concept of bioethics, for example, for this course is a very broad concept. It's much broader than we often use in the discipline, and that's probably to the discipline's detriment. The broad concept of bioethics was actually written about in a book by a man named Van Rensselaer-Potter, who wrote a book on bioethics in the late 60s. And he's sometimes credited with coining the English term bioethics for us. Another man named Sargent Shriver, who was married to Eunice Kennedy of the Kennedy family, is sometimes credited with giving us the term bioethics when they started the Kennedy Institute of Ethics at Georgetown in the late 60s, early 70s. All of this stuff's happening kind of in the same, Dan Clauser gets the late 60s, early 70s, these books are coming out. A think tank called the Hastings Center gets created in the late 60s, early 70s. All of that's happening kind of at the same time. And so then the 70s, we start publishing in this area. Now, the reason I'm telling you all this is we might call that late 60s, early 70s timeframe, we might call that the first wave of academic bioethics and humanities. And then in the 70s, with papers getting written, books starting to get written, presidential and congressional commissions on ethics in biomedicine and biomedical research and other things coming up, a new wave starts to hit at the late 70s and early 80s, a second wave, we might call it. And UMS, was part of that second wave. They hired in 1982 a man named Chris Hackler, who still lives here in town and actually has a place up in Rogers as well, because he's from Rogers, Arkansas. Chris Hackler was hired. He has a PhD in philosophy as well from the University of North Carolina. Was hired to start a division of medical humanities and bioethics. Medical humanities officially at the time, at UAMS, in order to bring humanities education into medical school, so that the idea that medicine is just basic sciences applied to human bodies wouldn't be the only way of thinking about medicine. And in fact, we would bring to bear the disciplines and tools, you might say, of humanities to medicine, which has always been a humane art, kind of artful form of scientific endeavor, but we had lost some track of that in our society. So UMS started in 1982 with this. And over the years, we have very, very slowly, frankly, grown up here. I was hired in 2004 from another medical school. And now we have 4 full-time faculty members who focus on humanities and bioethics, with another person who's part-time, who's PhD. She's an MD, in fact, but she has a PhD in medical humanities from the University of Texas Medical Branch in Galveston. So, so all of that kind of together is our little group here. And if you come to school here, you will, of course, get ethics education, whether you like it or not. You will get some introduction to the humanities in the standard curriculum, but we also have an honors track in humanities that 5 students a year are able to get into, so it can be competitive if there's more than 5 people who want it. 5 students a year can do that, and it's a 4-year honors track, so you sign up in your first year. There's also electives that we do in the humanities, including literature and medicine. I do a death and dying course, so today's talk, and we could go on, right? I mean, there's a caring for vulnerable patients. There's a history of medicine course on the books. We never seem to be able to teach it. That's another story. Talk about that later. But there are a number of different humanities courses on the books. So just as I'll do my sales pitch, come to UAMS, learn humanities while you're becoming a good healthcare provider, whether that's physician, nurse, pharmacist, whatever. Okay.
I'd say you have the right audience here for that.
Yes, yes, absolutely. Okay, so having said all that, get on today's topic. I do see John Hopkins has something here. It said, how do you think would affect a child if from birth its parents didn't impress any sort of gender identity? Well, in point of fact, I mean, how would I'm a philosopher, how would I know? But I do know, in fact, there's kind of this there's this small experiment, and I don't mean that it was done as an experiment, but you could, talk about it that way. I happen to know a faculty member in town who's not from UMS, but another university with a UA on it, who raised their children that way. And I don't know, I don't know what to say. The children grow up and do their thing, and they refer to themselves as they, and they seem to be fine with the world. So I'm beyond that, anecdote just says it's possible to do so and live a healthy life. That's all I can say. By the way, that's not a new question. That's not a new question of style, right? Parents talk about, should we raise our kids without any religion and see what happens to their religious identity and things like that, right? Well, I mean, it happens, and kids grow up and they develop whatever religious identity they develop, and is it good or bad for them? That's that value question that's not straightforward to answer, because it depends on what your purposes are. Values are weighable in relationship to one's purposes, and then purposes are weighable in relationship to the way we want to interact and work with one another in the world. So, all right, there you go. So let's get on with the topic of the day. And in fact, I'm going to tell you that I broadened the topic a little bit. And the reason I did is to put into context physician-assisted suicide. We can't just kind of go straight for it. Okay, so we're going to kind of come at it from a number of different angles. Again, if you have things to chat with me, you're welcome to throw them into the chat. There's a really good chance I won't see it as I'm talking, but we'll all work it out as we go through. We have plenty of time together. All right, so I want to talk about assisted suicide in relationship to the idea of controlling death. I don't know that this is the only way to conceptualize assisted suicide, euthanasia, anything like that. But I think it's a useful way to think about it, because I think in a lot of ways, that's what people are doing. Excuse me. I'm so excited by this topic. I can't control myself. Okay. So first off, we have to put into the larger context about this whole issue, dying, right? We have to essentially, any sort of death is, whether it's assisted or not, is part of the larger area of death itself. So there's approximately 330 million people in the United States, and life expectancy actually dropped in the last year because of COVID. And so, in fact, I think it's the average life expectancy is slightly below this at this point, than the 77.3. Notice this is 2020 data. So and in fact, it's the first time that life expectancy in the US has dropped in the last, I think, 40 or 50 years. I don't know the actual number. 3 million people in the state of Arkansas. I'm using Texas as just a comparison because they were about 10 times the size of Arkansas. So just to kind of give you a difference of how being in a different state with different populations and different systems might change things. So life expectancy in Arkansas, as usual, we are below the curve in many things. Life expectancy is 75 years, give or take. And Texas is slightly above the curve at 78. Note that as many people as there are in the state of Arkansas die every year in the United States. And the death rate is roughly 1 in 1,000, right? But slightly below that. In Arkansas, of course, our death rate is slightly above that. Yay for us. But this gives you a kind of context of how many people die in the United States. What are the numbers we're talking about? Now, this is the list of the leading causes of death in 2020 in particular. And you can kind of go down it and see it that this is in order and rank order in terms of the number of deaths in the United States. But what I want you to note is, at least in these cases, and in some of the others, depending on how you think of the idea of control, at least in these cases, many of these situations allow the person who would eventually or could eventually die of these conditions. There's a way in which they can control this, right? They have, many of these things offer time to reflect on how one wants to die, given these kinds of conditions. And frankly, if you have these conditions and you start to control aspects of your life in relationship to death and how you might want to die, you may in fact not die of these conditions per se, but you might be able to outlive the terminal nature of any of these. Note that there's a cost to all this. And when I say cost, I put it in quotes because it's not by any means just monetary. More than 70% of adults age 50 to 64 have 1 or more chronic conditions, right? And 50% have 2 or more chronic conditions. This is what it's like to get old, friends. Approximately 25% of people with chronic conditions are limited in their capacity to live independently or do everything for themselves. And 40% of US death occur to patients in the hospital. So if I were to ask you, where would you like to die? Where would you, what would the image of your perfect death kind of be? Most people don't say in a hospital bed. Most people say at home with loved ones around, or falling asleep in bed at the age of 173, right? Or whatever it is. And so the fact that 40% of people die in a hospital and another 20% die in nursing homes is just something you want to be aware of as a fact of life. The way we have, the way medicine works, the way we have medicalized death, and many other reasons are what push us into these institutions. Is that a bad thing? Not necessarily. It's just, it's something to be aware of so that as you think about a good death, for yourself or your loved ones, you need to conceive of it in relationship to what is practicable, what is possible and where are the best places for people to be able to live out their remaining days, weeks, months, however. There's a family impact. More than 1 in 4 families provide care for chronically ill, disabled, or aged family member or friend during any given year. So 25% of us, 25% of families at any given time are caring for a chronically ill, disabled, or aged family member. And that caregiving takes basically a half-time job, right? 20 hours per week. Now, that's not half of the hours per week, but it is a half-time job, right? If we think of our traditional jobs in the US as being 40 hours a week. There's this phenomenon we've labeled decisional conflict and regret, and these are things that unfortunately many families experience. So 2/3 of family decision makers have decisional regret. That is, after their loved one has died, we look back a year later and they talk about the regret they have for the decisions they made or were asked to make. And 40% have decisional uncertainty. Now, remember, regret may or may not mean that they may not like the decisions they made, but they made them in some sense. But at least 40% are saying they weren't even sure that they, about their decision. They didn't have any confidence in the quality or character of that decision. And this is an often quoted study because it's quite concerning that these 2 studies show us that after events where family members end up in ICUs and end up dying, the family members of those patients experience general anxiety, major depressive disorders, complicated griefs, and other symptoms that are symptoms for severe post-traumatic stress. And so these types of situations cause a major impact on families themselves. Now, I could also put up slides, and I didn't put them in here, but I could put up slides on how much end-of-life care costs. And it turns out we pay something to the order of 80% of our healthcare funding for a year in the United States goes to the last 2 years of life. So that kind of shows you even the actual monetary cost of these ideas. So I'm seeing some questions about like triage and issues with for physician assisted suicide. Let's get into some of these discussions a little bit further, and then we can maybe talk more about those particular questions. All right, so all of that is just laying out context, and I think it's an important context. We can talk more about the broader context. I have slide decks and stuff with other data and information if there's other things you want to drill into, or I can just make stuff up because I'm really good at that. Philosophers do that all the time. So I make stuff up too, but we could talk about the larger context later. I just wanted to put a few of those slides in for this. What I want to turn now is to defining some of these concepts that float around in these discussions and often can be confused in these discussions, or at least have certain relationships to one another. And so I want to be sure that we go through definitions. But to do that, let's think about 3 different kinds of cases. So Mr. P has a pacemaker, an implanted cardiac device. And he has it because he has congestive heart disease, and it's what's keeping his heart thumping regularly when he needs to. He's 78 years old, and for the last 6 months, he has been feeling particularly bad, kind of decompensating, and his pacemaker is going off more regularly to keep his heart going, which he hates. He just thinks it's terrible. And he's talked with his wife, and he's decided it's now time to turn off the pacemaker, which may not immediately, but could very soon result in him dying. Ms. N is a 92-year-old woman who was in a nursing home and with some advanced dementia. She can sometimes talk and interact with the people in the nursing home, but she's not fully aware of her environment, and she's not, she doesn't necessarily interact in deep, meaningful ways, but she's able to say things once in a while and do things like that. Unfortunately, her GI tract started getting what's called adhesions. It was starting to basically get kind of scar tissue built up inside it, and so it was getting blockages in her gastrointestinal tract. And in order to do something about that, she was sent to UAMS, where the physician, when upon arrival, the physician talked to the family and said, we need to do this if you want her to get better. It might require us to do a couple more surgeries as time goes on, but right now we need to do this or she'll die. And so they do the surgery. And 10 days later, the surgeon is looking at films and looking at her labs and realizes that sure enough, they're going to have to go back in and clean out some more of the gastrointestinal tract, clean out some of the scar tissue, open up some more adhesions. But this time the family says no. And the surgeon gets quite agitated by this. And in fact, turns to them and says, you're killing your mother. We talked about this and I said it might take more, and now you're not letting me do it. So why did we even start down this path if you didn't want to go all the way down it? So interesting question. We'll talk more about that case. Third case, Mr. R has lived with chronic obstructive pulmonary disease, COPD, for many years. And unfortunately, over time, eventually his lungs have decompensated and he ends up in the ICU and on a ventilator. And he's been there now for 2 weeks. And the discussion is that if we're going to keep going, we need to trach him, open up a hole in his neck and put the ventilator to the trach. But we don't think we should do that because we don't believe that his breathing's going to get any better. And so even if we do that, he will be on the vent forever, and he might not even come back and regain consciousness from this whole event, so that we think it's better for him to die. His wife initially says, absolutely not. We are going to keep going. That's what I want to do. His son eventually comes in and talks with his mother over a few days, and they decide, no, in fact, we'll go ahead and we'll stop the ventilator. He really wouldn't want to live on the ventilator. But after they take the ventilator off, it's not that he dies immediately. In fact, he goes into what sometimes described as air hunger, gasping for air and continuing to do that. And the family is at bedside and seeing this and is very distressed by this and asks why we can't give him more medications so that he is not suffering in the way that he is. These are different kinds of cases. In what ways do they equate to acceptable ways to die, unacceptable ways, acceptable ways for healthcare providers to act in those cases, or unacceptable ways for them to act? These are some of the concerns that come up. And each one of these cases pushes on a concept we sometimes talk about, and it's a problematic concept we sometimes talk about as futility. That these cases raise the question of whether or not what we're doing in healthcare is futile. The ancient story of getting water from the well, and yet it drains out of the pots and jars. Futilis, futile. But in medicine, it's no simple concept. What does it mean to be participating in something that's futile? If we could pin down the concept, then we would know that physicians, when they should do something, or at least be talking about doing something, and when they shouldn't be trying to do something at all. Because if you're going to, if the thing that is being requested or the path that is being proposed is futile, you shouldn't be involved in. It's not going to achieve the goals you want. But what is this futility? And in the 1990s, there was a lot of discussion about this. What is it? How do we define utility? And three kind of general areas came up. We could define futility physiologically. That is, if we propose a therapy that simply won't have the physiologic response that it's proposed for, well, then it's futile. Physiologic futility. The classic case is throwing antibiotics at a virus. Antibiotics won't touch a virus. It would be futile to do so. And yet, sometimes, in fact, we do it. In fact, we do it all the time in kids who have otitis media and ear infection, even though 75% of the time, those ear infections are viral. 75% of the time, we give parents amoxicillin to give to their child. Physiologic futility. Then some people posed what came to be known as quantitative futility. If in the last 100 cases of X, you have not gotten a response, then it's futile. So we've gotten less than one response, well, one or fewer responses in the last 100 cases, it's futile. The third is qualitative futility. That is, it's just not worth it. We could try it, but we don't think it's worth going through it all to try to achieve ends that may or may not come to fruition. But here's the problem with all of them. Physiologic futility is actually quite rare. Like the otitis media case, there are two reasons we throw amoxicillin at the child. One is because we don't want to deal with the conflict with parents. Quite honestly, human beings are conflict averse beings, so we tend to try to avoid that conflict. But the second reason is we don't culture the ear to find out whether or not it's bacterial or viral. So we sometimes throw it at it saying, well, if it's bacterial, it'll touch it. And if it's viral, it won't really hurt the child anyway. So go ahead and do it. But the problem is we still don't know if it was physiologically futile or not. It's just hard to know that. If we knew it, then we wouldn't do it, and it would be a pretty clean case. But that's pretty rare. The problem with the other two is they both come down to judgments of worth, because even quantitative futility, if we can turn it into numbers, we're saying that certain numbers are worth it and certain numbers are not, right? But we tend to, as family members, see our other family members as MasterCard ads. That is, they're priceless, right? $10 for this, $20 for that, but this, my child, my aging mother, priceless. And so you tell me there's a 1 in a million chance, and I might say it's worth it. Whereas what you're saying when there's a 1 in a million chance as a provider is, let's not do it, right? And so we have this challenge of who's right, who gets to claim what's worth it or not. So futility isn't really the best route to go down when it comes to whether or not to do something. In fact, it's much better to have a discussion about goals of care. What are we trying to achieve? And we'll get to the goals of care part in a little bit. And whether or not it's futile relative to goals of care may be in the background of our minds, but what we're really trying to do is talk openly and honestly and transparently about what what we think we can achieve and what the family is looking for. And if we can come to agreement on that, that might actually be much better than throwing around terms like futility, which actually end up being fighting words in the hospital. If you say futile to a family, they get quite upset. Now, I want you to think about the fact that one of the things we do all the time in medicine is withdraw interventions. We also put interventions on people or use interventions. We give them medicine that they take. We implant devices. We do even things like temporary things like interventions of putting casts on broken arms and all these things. But for all those things we do, we also very commonly withdraw them. One of the things that made us very nervous in the 1970s, because things like ventilators were still relatively new things, in the 1970s, we were very nervous about withdrawing ventilators. The reason for that was we withdrew the ventilator, the patient would die. And there's this kind of general, again, we used the term yesterday, today we'll use it again. There's this general kind of myth that medicine is about curing and keeping people alive. It isn't. Medicine is about living healthily so long as one is alive. And we will maximize the opportunity to live healthily so long as someone is alive. But medicine is not necessarily about keeping people alive. That's a determination that happens by condition and by the person, him or herself, themselves. All right, so we can withdraw ventilators. We've come to get comfortable with that in medicine. We've been less comfortable with assisted nutrition and hydration. I have another slide on that to talk a little bit about that. We only, in the last 20 years, really started to get comfortable withdrawing dialysis from patients. Again, the reason being, dialysis seems like a kind of miracle intervention. Your kidneys, a kind of vital function of your life, your kidneys shut down and won't do their work. And dialysis takes over that work, but takes it over in such a way that you don't have to be on it all the time, and you can go live your life out in the world, at least for many people, not everybody, but you can go live your life out in the world so long as you come back and get dialysis regularly. The problem is, of course, dialysis regularly is 3 times a week, 3 hours each time. And that's for those people who can ambulate, who can get out into the world. For somebody who's in a hospital in an ICU, who may also be on a ventilator, may have congestive heart failure, and their kidneys are shutting down, it's not clear what dialysis is really doing there other than simply performing the function of kidneys. But is that making them better? Right? Is that helping them live a better life? Interesting question. Again, ventricular assist devices, this is, you might call an external heart pump, all right? Somebody whose left side of the heart is not doing the work, you can put this external heart pump on them and it'll take care of that. If you remove it, they will die. But we've determined that that's okay. Some surgeries, certain antibiotics, and we can go on. And the reason I want to point this out is when this originally was discussed, and I think, if I'm not mistaken, I gave you all a paper on this, but when this was originally all discussed, removing such things we called passive euthanasia. And the term euthanasia is a loaded term, and one that we will talk more about in a minute. But now it's just seen as withholding, withdrawing life-sustaining measures, which is a right of an individual to exercise. Individuals are allowed to refuse any treatment on their bodies because of that issue of respecting someone's autonomy and their bodily integrity. That we don't get to go cut on people, shove things into them, or anything like that unless they give us permission to do so. And if they withdraw that permission, then we should also withdraw those interventions. And it's taken a while for us to get there in medicine, to get more comfortable with that idea. And again, we're not necessarily comfortable about it in all places. In fact, the pacemaker case I gave you, just about, it was about 5-7 years ago, a couple of people wrote on this saying, absolutely not, you can't stop a pacemaker. Once it's in, it is part of your bodily integrity, and to stop it, for a physician to stop it, is to kill the patient unwarrantedly. Other people disagree. It's a medical intervention, and if somebody wants that medical intervention out of them, so be it. Now, one of the places that is still a bit controversial as well is artificial nutrition and hydration. And our laws even recognize this. So one law in the state of Arkansas, it's an old law called the Arkansas Rights of the Terminally Ill and Permanently Unconscious Act. We just call it ARTAPUA. ARTAPUA actually says that if you write a living will, you should specifically say in it what you want to do about artificial nutrition and hydration. The law singles that particular modality out and says you should say something about it. The more recent law called the Healthcare Decisions Act doesn't do that, but it does do this. It says if a surrogate who is named by the physician to make decisions for the patient, if a surrogate named by a physician to make decisions for the patient wants to stop artificial nutrition and hydration, you have to get a second physician's opinion before that can be done. That's not true of ventilators. It's not true of dialysis, but it's specifically true of artificial nutrition and hydration. Well, why is that? Well, because there's a sense that people hold that feeding and eating is a kind of fundamental, what Catholic theology calls an ordinary aspect of one's life, and that our helping to feed others is part of our everyday duties. But that's an interesting claim, right? Wouldn't breathing be just as fundamental? And if we could help somebody to breathe, and of course in medieval Catholic times when these kinds of distinctions came up, we couldn't really do much about that. But now that we can on a regular basis, shouldn't we have the same kind of ordinary duty to help people breathe? But no, somehow that's considered, again, in the language of, in this kind of language, extraordinary. It is above and beyond our obligations. Well, then why isn't artificial nutrition and hydration stuff that has to be done by a clinician and can only be regulated through medical practices? Interesting question. And I think, frankly, it fails the test of being something to be set aside different from dialysis and ventilators and those things. But again, not everyone agrees. Okay, but we've already used this term, so let's go ahead and start to use our definitions and define things. Euthanasia. Euthanasia is based on Greek language, eu meaning noble, good comes from the same root, and thanatos, death. In everyday language, we tend to think of it as mercy killing, as opposed to murder per se, right? We set it aside from homicide or murder because it's mercy killing. It is done for merciful reasons. Technically, in medicine, the definition is kind of more like this. It's an act by a medical professional where both the means necessary, how we're going to do it, are provided, and the final act, how it's going to happen and who's going to do it, causing of death, is performed by the professional for merciful or beneficial reasons. Okay, that is, from the standpoint of the person doing the act, this is a merciful act, not a nefarious or vicious or evil act. It is to ease pain or suffering, something like that. Now, in our language today, and if you look back again, 20, 30, 40 years in the literature, this isn't always true, but for the most part in our language today in medical ethics and in medicine writ large, when we talk euthanasia, we are typically talking about those acts where a patient with decisional capacity, who's deemed competent by the courts and has capacity according to clinicians, requests that. It is what we sometimes call voluntary euthanasia. And it would also constitute active euthanasia. These are old-fashioned, active and passive is an old-fashioned distinction. Very few people use it anymore because instead of talking about passive euthanasia, we talk about withdrawing life-sustaining measures according to ethically appropriate means. And we rarely use active now because we don't need to distinguish it from passive. That is, euthanasia is an action where the actual action is the cause of death, as opposed to passively standing away and, oh, look, the guy died. Now, there is this distinction between voluntary and non-voluntary, and there are some challenges with this depending on countries' laws and stuff like that in this regard. And speaking of countries' laws, United States does not allow legal euthanasia. A physician or other person cannot kill another person for merciful reasons, right? Cannot provide the means and be the final actor in doing that. Euthanasia is legal in places like the Netherlands, Belgium, there are a few other places where it is legal. And if you follow appropriate steps that are in the law or that courts have carefully mapped out, if you follow those steps, you are protected by law should you do that. Again, this is all on under the umbrella of medicine, so it's not any old person can euthanize somebody. A clinician with a license and all that stuff can in these countries. Just a moment on this idea of double effect that some people hear. So, if we think of the third case of Mr. R, when he's suffering from air hunger, the family's saying, can't we give him something to speed this up, right? To help or to ease his suffering on this. And clinicians begin to worry, if I do that, will I be euthanizing him? That's why this concept comes right after euthanasia. They worry that it could be euthanizing him. They would be hastening his death through their means of, say, adding opioids that depress respiratory drive, right? And so if I give too much of that, then of course he'll stop breathing and he'll end his suffering, but he'll stop breathing and then he'll die. Well, again, pulled from, frankly, other contexts out of Catholic theology is the idea of the doctrine or rule of double effect. And it goes this way, it says, where an action has several expected results, right? You can do something and you can foresee the possibility of going down several paths by this one action. And some of those paths are good and some bad. And you're standing at the crossroads, not sure which path will actually end up happening because you don't have full control over that. You have some, but not full. The action is justified, provided that A, the bad outcomes are merely foreseen and not intended. So here we are, possibly pushing opioids on somebody with air hunger. And you ask yourself, well, am I going to kill this guy? That would be, for me, a bad outcome. I'm going to kill this guy doing this. So that's a bad outcome. So, and I could foresee that happening, pushing opioids, but I don't mean it to. I'm not intending, that's not what I'm trying to do. And in fact, I'm titrating the amount of morphine in such a way that I hope all I'm doing is easing his suffering so he doesn't feel so bad, but not that I'm giving so much that it depresses his respiratory drive and kills them. So that would be first. Second, the action can't be intrinsically bad. And pushing morphine in order to ease suffering, pushing morphine in general is something we do all the time. It's not intrinsically bad. We intended to ease suffering. It in fact eases pain and suffering quite often. So it's not an intrinsically bad act. The good result must not itself be a result of the bad result, or a direct result. In other words, you can't go through the bad in order to get to the good. So if we were saying the only way to ease the suffering is to kill him, then the doctrine of double effect would have a problem, right? Couldn't support the act. And the good and bad results must be proportionate. That is, they can't be wildly disproportionate, such that the bad is really, really bad and the good is just or vice versa, right? Now, this is a moral justification that clinicians to this day will still cite in some of their actions. I doubt they could actually name these 4 properties. B, they just know I didn't mean to do it, and so I shouldn't be on the hook for it. And so whether or not, and thirdly, philosophers don't all agree that this is an acceptable rationale for supporting, morally supporting our acts. In fact, some would say those acts are supportable, but the doctrine of double effect is not the way to support them. So there's a debate just on the philosophical side as well. But to be clear, I guarantee you we could go into a hospital and I could poke somebody and they could tell you that there is some concept of double effect. They might not entirely understand it, but they know it protects them, morally in certain situations. Okay, euthanasia, double effect, suicide. I'm getting closer. I know, and we're what, 4 hours in, and we're almost there. All right, suicide, an intentional act by a person wherein they take their own life by means at their disposal. The person who dies is also the final agent of death. Okay, so suicide is that intentional act where I'm intending to kill myself, I find a way to do it, and I do it, right? There you go. Some people still believe the myth that suicide is illegal. It isn't illegal. That is, it's not a criminal act. If, however, you attempt suicide, it is caused to put you on a 72-hour hold for psychiatric reasons, and you could get involuntarily committed to a psychiatric facility, not jail, right? And you don't go, you yourself don't necessarily go before a judge or anything like that. The medical providers might go before a judge in order to get you involuntarily committed if that's what they determine is best for you, because you are a danger to self in those cases. But it's not an illegal act that would imprison you. At one time it was, by the way, but it is not, and it's not in any state. So how does suicide differ when it's called physician-assisted suicide or provider-assisted suicide, or however it gets couched? Well, that's an act where a patient, again, the patient themselves intentionally takes their own life through means that are provided by a professional, a physician, like drugs. So the physician is gatekeeper of the pharmaceuticals, and that's why we have to go through them if we want to kill ourselves using that means. So the physician becomes a necessary actor in this process. And the question ethically is that an ethical problem for a physician in their role as physician to play, right? Should they play that role in helping somebody kill themselves? And we'll talk a little bit about how this has come to be. But I want you to see that conceptually and practically, it differs from euthanasia, which oftentimes, if you read some literature or hear some arguments or just are talking with your friends on the street, because we all do this, we all stand around in parties and talk about euthanasia and physician-assisted suicide. Well, reality is when people talk about it, they often just conflate the two and say euthanasia, physician, it's all the same thing. It isn't, at least from the standpoint of where the final agency falls. So where the physician is the final actor in euthanasia, the patient, him or herself, is in physician-assisted suicide. And therefore, the locus of control for that final act falls somewhere else. It falls to the patient, him or herself, and leaves them with the ability to control whether or not it occurs in a way that euthanasia doesn't. Legally, it is physician-assisted suicide is legal in all of these areas in the United States. Every year or every 2 years, depending on how legislators work, ours works every 2 years or so, states continue to consider physician-assisted suicide laws. And some states pass them, some states don't even get out of committee. In fact, the state of Arkansas in 2019, one of the state legislators dropped a bill on physician-assisted suicide into committee, and it never got out of committee. But don't think that being in Arkansas means that it's not coming or that it hasn't been considered. It has, at least the process of thinking about it has already begun in the state of Arkansas. Will it ever pass? I mean, I don't know. I'm not betting on such things one way or the other, but just know that this is the kind of idea as part of now the social fabric of our lives that will be that will continue to come up, especially as more and more states pass laws that recognize it. I will point to the Oregon statute as the kind of paradigm. It was the first one. It was passed in 1994 initially, and then the courts held it up, and they held it up so long that what they essentially did is people in the state of Oregon just went ahead and put it back on the ballot in 1997 and said, all right, you're not going to let us do the original law. We'll just try to pass it again. And they did. They passed it by an even larger majority the next time. And so in 1998, the very first acts of assisted suicide were legally protected in the state of Oregon. Oregon also has data from every year about how this happens, who dies, how many people get prescriptions, how many people follow through. In point of fact, as high as 25 to 30% of people who get the prescription don't actually follow through. And you have to recognize that you have to be able to swallow the prescription. They are pills that you have to be able to swallow. No one injects anything. So and part of that is, again, that conscious act of having to take your own life has to kind of be obviously so. So you can see, again, in this kind of paradigmatic style of legislation, you have to be an adult, 18, you have to be capable, you have to have decisional capacity. So you can't lack decisional capacity. You've got to have decisional capacity so that your decisions are autonomous. You have to be diagnosed with a terminal illness by a physician that would lead to death within the next 6 months. The patient has to make 2 oral requests separated by over 2 weeks, and then a written request that's signed in the presence of 2 witnesses. The prescribing physician and consulting physician must confirm the diagnosis. Prescribing physician and a consulting physician must determine whether the patient is capable. They don't have to get a psychiatric evaluation, but the physician can require one if that's what they believe is necessary. The prescribing physician must inform the patient of other alternatives, including hospice and pain control. The prescribing physician must request, but may not require the patient to notify next of kin about the prescription. And then all of this also has to be reported to the Department of Human Services, which is why we have the data on all of this. Not every state actually has passed the kind of data collection law portion of this. So Oregon's been in front of all of this so that they capture data. Because one of the concerns about physician-assisted suicide is that it would, when it was first happened, that it was going to end up targeting and affecting vulnerable populations, underrepresented minorities, folks with lower socioeconomic standing, those kinds of things. In point of fact, it's actually the opposite, which has its own equity concerns. And it turns out it's upper middle class white women are actually, I think, the largest portion of people who end up doing this. So as I said, in the state of Arkansas, there was an attempt in 2019 to pass such a law, but as it stands right now, the law in the state of Arkansas says it shall be unlawful for any physician or healthcare provider to commit the offense of physician-assisted suicide. So there's a statute on our books right now that explicitly makes it a criminal act to do so. So it would have to be a conscious change to the law to allow this. You may have heard of, though you're all quite young and who knows, a guy named Jack Kevorkian from many years past. Jack Kevorkian was a pathologist who believed that assisted suicide and controlling death was kind of right of citizens. He set up a way for people to follow through with assisted death on his own. And he did so in the state of Michigan because Michigan didn't have an explicit law that said assisted suicide was against the law. Eventually, actually, they passed some stuff on that in Michigan, but that's why he chose Michigan as opposed to a state like Arkansas that has that explicit language. So I mentioned that in all of this, we need to think about care and goals of care. And to start thinking about that, we have to think about what medicine is about in terms of spheres of care. Where does healthcare fall? Healthcare is always care. One thing that irritates the out of me is when I hear providers say, we're going to withdraw care, or the family wants to withdraw care on this patient. We never, ever, 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 and let's put one more in there, ever withdraw care on patients. We provide care the whole time. However, we may withdraw interventions. We may withdraw treatments that would, in fact, end up leading to death. But that's only because we do so in light of care, not because we're withdrawing care. And within this realm of care, there are two general approaches to care. What we might call the traditional concept of curative care. When somebody hits the emergency room, we want them to start from the presumption, we're going to see what we can do to fix the problem. And when you show up at a doctor's office, that's kind of the basic prevention we want all of our physicians and healthcare providers to have. But for some patients, there's a moment at which turning towards comfort care, where we focus not on cure, but on making someone comfortable until they die, becomes the primary focus of our work. And so that the orders we design and develop for the patient are with the idea of comfort unto death in mind, rather than cure or fix or things like that. So I want you to kind of see that all of this falls within the spheres of care that healthcare provides. And I said a little bit earlier that refusal is an important part of the decision-making process. That is, the ability to consent implies that there's a possibility of dissent. Otherwise, we don't need people's consent. We just shove them down the path that we want them to go down. But once we decide that it's important to have a patient's consent, and we have decided that as a society, then we have to accept that there's the possibility of dissent. So when Ms. S comes to the emergency department from the nursing home, her son comes in 45 minutes later and sees that she's on a ventilator in the emergency department and is stunned by this because she wouldn't have wanted that. And they'd had long conversations about this when she was going into the nursing home. And he asks that they take her off the vent. And the ER says, not here, that's not what we do. We will not withdraw. Ms. V has an anoxic event, loses oxygen for a significant period of time throughout her body, which means perfusion of oxygen across the body has stopped, at least for a period of time, or at least really reduced badly. One of the things that got injured in this were her kidneys, but also her brain. And so because her kidneys were injured, she got on dialysis. But because her brain was injured, she's sitting on a vent and unable to interact with the world. Again, the family turns and says, can we stop the dialysis? It's unnecessary. And the nephrologist says, it's doing its work. I won't stop it. So how do we deal with that? And again, I want you to realize that there is a right to refuse. Patients may refuse authorized treatments and interventions. You cannot medically touch somebody without their permission, in the same way that I can't just go touching my students without their permission, right? I mean, and even with their permission, the power relationship already, creates some problems. Well, that's also true in medicine, right? There's a power relationship in medicine as well, so that permission alone isn't enough. You need to get a fully informed consent, and the refusal, of course, should also be informed. This right to refuse comes from at least 3 other rights we readily recognize in society: that individuals have a right to privacy, that they have a right to self-determination, autonomy, and that they have a right to their own bodily integrity. And as such, they should be allowed to refuse, which then leads to foregoing life-sustaining treatments. Foregoing life-sustaining treatments is an act where a physician, after request of a patient or their surrogate, withholds or withdraws resuscitation efforts, medication, ventilation, food and hydration, etc., which is helping sustain biological functions of the patient. Again, some have called this passive euthanasia. Others describe it as cessation of extraordinary means. But I think it's best understood as exercising that right that we have to refuse things happening to our body that we don't want to have happen to our body, even if it means death. In fact, when I say that surrogates can do this, the Supreme Court of the United States has affirmed that as well in a case called Cruzan versus the Department of Health of the state of Missouri, where the US Supreme Court said, look, each state can set up the rules by which surrogates make decisions for patients. And the state of Missouri, being the show me state, has a bar, a threshold they call clear and convincing evidence. You must provide clear and convincing evidence that you as a surrogate know what the patient would want. And the US Supreme Court said, that's fine. You're absolutely welcome to set up that rule. But if someone meets that, you have to allow them to exercise it. So it's not just the patient, him or herself, who has to say this. The surrogate can say that so long as they can show in the state of Missouri that it is what the patient would have wanted with clear and convincing evidence. Each state has its own set of kind of guidelines. All right, so I want to finish. I want to finish. I know this is a talk about assisted suicide and these other challenging modalities, but because this is all under the umbrella, I would say, of how one can take some control over death, I want to finish by talking a little bit about advanced directives. I'm not going to go into great detail, but I want you to think about what it means to plan your later years and your end of life issues. What we call planning, the general term for planning at the end of life is called advanced care planning, ACP. And the initialism or acronym, or however you want to think about it, that I use to help think about ACP is ISEP. First off, if you want to start thinking about how you want your life to proceed unto its end, you need to start by identifying what are the relevant values and interests you have in relationship to living and dying. Who are the important individuals that you want involved in these kinds of ideas and discussions and decisions? And what kind of support systems are available to you as you move through those stages? Then you need to have conversations with healthcare providers and family about this. This is where we don't do the identification. We certainly fail at the communication and conversations. We rarely talk to one another about these things. We are afraid to talk about death. And in fact, the people who are probably most afraid to talk about death are adult children with their parents about their parents' death. Parents sometimes are more willing to talk to their adult children than their adult children are willing to talk about death. Adult children don't want to think about their parents dying. But if you don't have these conversations and your parents get gravely ill or injured, are you ready to know how to help make decisions and move through that time frame? If you can't answer that confidently, then you need to have those conversations. You need education. You need to understand what the current health status, your or the patient's current health status is. You need to think about what possible future conditions the patient or you or whatever would have. But you also have to think about healthcare options. So a lot of times we hear families tell us, oh, he never wanted to be on machines and he thought tubes were, all these machines and tubes, he wouldn't want to live that way. But that's not necessarily the same as saying he wouldn't want to be on a ventilator, because sometimes you can be on a ventilator because of a bad pneumonia or after a car accident where your respiratory drive is temporarily repressed or depressed. And so then you're on for 3 days, you're on for 3 weeks, but you come off. And if you don't give that chance, or if you don't know that chance is possible, then you don't know what healthcare options are truly available to you. So you have to talk about those things. Yes, some people may never want to be on an event, regardless of if it's 3 days versus 3 weeks versus 3 years. But most people just think, if I get on a machine, I will never come off. That's just simply not true for many people. Finally, you have to do paperwork. You need to write it all down. And the way you write it down is either, or both, I prefer both, a treatment directive or a proxy directive. A treatment directive says, this is what I would like to have happen. If certain conditions happen, these are the treatments I want, these are the treatments I don't want. A proxy directive says who you would like to make decisions for you. That can be anybody you think is best positioned to speak your voice at that time. And yes, we want somebody who can speak your voice, not their voice. It's hard to get out of your own way sometimes, in terms of like being the child of an adult who's in the ICU. I often hear from adult children that they know this isn't what mom would want, but I can't make the decision to not do it. Those kinds of things. And you have to be able to find somebody who can get out of their own way and speak your voice. And this paperwork, these advanced directives, are triggered in particular ways depending on the state. Health law is state law. Each state has its own set of laws according to health, about health law, and each state may have different rules regarding that. So in the state of, say, Pennsylvania, your living will gets triggered if you're permanently unconscious. In the state of Arkansas, it's if you lack decisional capacity to make those decisions. And those are two different things. The other way something gets triggered is how you write it up. So in the state of Arkansas, there are still older living wills that say, if I am terminally ill or permanently unconscious, please follow this. Well, then that means that's when it kicks in. Even if you lack capacity and you need somebody to make decisions for you, or you need decisions to be made for you, the living will doesn't kick in if you have the caveat up top that says, if I'm terminally ill or permanently unconscious. So then the physician has to go through another process to find somebody to make decisions. Whereas if you don't have that caveat, you say, when I lack capacity, decisions need to be made. Here are the conditions I'm worried about. Here are the decisions I want to make. That's a better way to write your living will. Gives more flexibility. My last slide. Everyone, I don't care how young you are. Well, I care that you have to be 18 at least to actually do one of these in the state of Arkansas. But if you're 18 or older, write a living will. You can change it in 3 years. It's fine. You can change it in 10 years. You can change it every 3 minutes. Don't do that. That's crazy. But you could. But we should have them, because sadly, and unfortunately, because of where I work and who I work with, I see far too often many people much younger than they should be dying. And there's any number of reasons it happens. And the more you can prepare, the better you help your family avoid things like decisional regret, right? Because they know better how to make those decisions, because you've had those conversations, because you have that paperwork, and you ease some of the burden for your family. Whew, all right, that's still a little earlier than we need, so we have some time to have some discussion before our break, but I wanted to tell you all that, and I'll stop our share now.
Thank you for another fantastically comprehensive look at a tough topic, and I want to remind you all we're very unfortunate to have someone who is speaking from his actual area of expertise these days, today, and I think is giving you all some great things to think about, as well as some good practical advice. Let me speak from the perspective of someone who's your parents' age or a little older. Having an advanced care directive, having a living will is incredibly important, and encouraging your parents to do so is incredibly important, because at some stage, more likely than not, it will come into play. And when you've had these conversations, you feel a great sense of relief compared to the uncertainty and the self-questioning you feel if you have not. And that's speaking from personal experience. So I see there are several questions in chat, and I bet there are several people who want to jump in.